So hi everyone, I'm Jaikaran Singh. I'm a pediatric cardiologist. I was at Echo 2 years ago and I was logging in from Omaha, but I am now back in Honolulu, Hawaii. Very excited to be back after completing my training. And yeah, I was just thinking about topics to go over, and I thought cyanosis is a good one because it can be very variable and lots of presenting factors. So yeah, I guess that's why they call it the blues. I'm pretty sure it came out before I was born, but that song. But anyway. So yeah, as mentioned, no conflicts of interest. There are aspects of this that are pulmonology, neonatology, emergency medicine, and intensive care. Again, those are not my specialty, so a lot of the focus will be on uh, cardiology, but there are multiple causes. So yeah, just realizing that, and if there's something a pulmonologist or some their specialist says differently, keep those in mind as well. So we've gone over the objectives just a little more. So we define cyanosis, hypoxia, and hypoxemia, and I will admit I also have used those words interchangeably, but they are different uh, terms. And then going into the common causes and management. Cyanosis can very often be benign, so I think part of this talk is reassuring families when it is benign, and hypoxemia goes into when it's not benign, so the consequences. And lastly, just to focus on my specialty, some cardiac causes of hypoxemia, this won't be comprehensive, and just a few more special situations. So just going right into the definition. So cyanosis is bluish or purplish discoloration of the skin and mucous membranes. So this is a clinical sign or a symptom if um and yeah, so if the kid appears blue, it's called cyanosis. It doesn't mean the saturations are low. So hypoxemia is if there is reduction in the blood oxygen levels. So you're satting in your 80s and all of that, your PA2 is low, and hypoxia, which also we use, I think, pretty interchangeably, but that is when the tissues are not getting enough oxygen. So you could have a kid, like the mild bronchitis who are satting 90-92%, and mildly hypoxemic. They may not be uh, incredibly hypoxic at that time. So with normal hemoglobin, uh, it's usually estimated, and that's in the 13 to 14 range, a saturation of around 80% will cause cyanosis. Cyanosis is, and I just actually looked into this paper today. It's not sensitive and specific when this is a 30, 40-year-old study, but interestingly, like when patients were or providers were shown a SAT of 85%, I think one-fourth of them would not recognize a 80 or 85% just by clinical examination, and 10 to 15% will call someone with SATs of 90 to 95% as cyanotic. So there is variability. And this is just so your goal is you're evaluating cyanosis because you do treat the case of cyanosis. You want to figure out if there's hypoxemia and you want to prevent hypoxia. So it's a clinical sign and you need evaluation to determine an etiology. And I think we've gone over peripheral versus central in our training. Peripheral is the arms, the legs, the hands and feet, and central is the mucous membrane, so the inner lining of the lips, the oral mucosa. And in general, peripheral cyanosis is benign, and central cyanosis is a mark of hypoxemia. Because if it's affecting your mucous membrane, you're probably actually seeing those low saturations. Another thing I hadn't put in the text, but is that depending on the ethnicity or the skin color, cyanosis may be more difficult to detect. In African Americans, I believe it's a on average, you're getting 6% lower saturations to detect it. And in our population, it's probably somewhere in the middle. It hasn't been studied, of course, separately. So just a few terms involving cyanosis. The first, so you've got perioral circumoral cyanosis. So that's the area around the lips. Acrocyanosis, like we talked about, feet, the hands and feet. Differential cyanosis and the rarer term reverse differential cyanosis. So this is when you're going into cardiac terms. And that basically means when the saturations in the upper and lower extremity are different. Most often you're going to see these in neonates. In fact, like what this picture shows, you're not going to have differential cyanosis without a PDA because the cause of the saturation difference is your patent ductus arteriosus shifting desaturated blood to the area beyond that point. So if it inserts between the carotid and the subclavian, you'll see it. You may see it in the left hand, but more often left legs are the ones with the lower sats. So you do need a PDA to have a differential cyanosis, or in much rarer cases, an AP collateral. Classically, differential cyanosis is your saturations in the upper extremity, right upper extremity are normal, and then beyond that point are lower. So in your newborn screen, it's a difference of 3% or more. Reverse differential cyanosis, which you only see in transposition of the great arteries with elevated pressures, is your sats in the lower limbs are higher than in your right upper limb. That being said, most of the time the sats are low throughout. So we talk about, maybe 80, high 80s here and 70s there. Whereas in normal uh, differential cyanosis, you may have normal sats in the right upper limb. And then we have pseudocyanosis. I think I'll talk about that in a slide. And that's, you don't really have it's more due to discoloration of the skin and not necessarily anything with uh, the saturations. So I think the most common thing we'll see in pediatrics is actually acrocyanosis, which is symmetric blue and purple discoloration of the extremities, no clear line of demarcation. So you can see it'll generally fade. We most commonly, the story we hear is we see it in infants, but can be in adolescents as well, and honestly can be at any age group. So there's no, if everything else is reassuring, there's not a specific age which should worry me for acrocyanosis. And it's thought to be due to vasospasm of the cutaneous arteries and venous pooling. So what's happening usually in cool environments or bathing, if there's vasoconstriction and blood is flowing slower through the capillaries, two things are happening. Firstly, there's a little bit of venous stasis or pooling, and you're seeing the veins more prominently. But also when blood is moving slower in those areas, they're extracting more oxygen. So in general, the blood in your veins may be a little more deoxygenated, which is fine, right? Your blood in the veins is supposed to be deoxygenated, but it's even more prominent because and you can have delayed capillary refill as well, again because it's slow blood flow and all. With cool environments, I've said it's often in cool environments. I've heard, there are components of vasoreactivity, which every child is different. And I've heard families say, oh, it wasn't that cold. So you don't need to hang your hat on that. Like if you have acrocyanosis and they say it's warm, it's still possible. It's just classically should be cool. And that's just because you've got the vasoreactivity and all that happening. And no diagnostic tests are indicated. So no real invasive blood testing, imaging. Um, but you would still, get the vital signs, get the saturations, do all of that, especially if it's in front of you. Again, because I talked about the low sensitivity and specificity. Just because it looks blue doesn't mean the saturations are abnormal, but also just because it looks okay doesn't mean uh, you couldn't have hypoxemia. So secondary causes, ADHD medicines have been known to cause it. So the stimulants, again, due to vasoconstriction at the peripheral small blood vessel level. Uh, it's important to mention it isn't a reason to stop the medication. Uh, so you can continue it. It's a risk-benefit thing. Acrocyanosis is non-painful, but if it's causing some discomfort, you can discuss changing. And then anorexia nervosa Ehlers-Danlos, and Pott's autonomic dysfunction. All of these, like we know with anorexia nervosa also, they have symptoms of POTS and they have like bradycardia due to vagal tone. So you've got this abnormal autonomic response happening in all these situations, which can be underlying causing the acrocyanosis, but again, emphasizing it's not harmful. It's just the blood flow through the capillaries at that point is a little slow. It's still getting back. Your cardiac output's still normal. And that's how I usually counsel families as well. It's a normal finding. It's we're seeing the veins more prominent due to blood flow at that time, but if the if you're well oxygenated, it's not worrisome because we're worried about being blue because the concern is the body getting enough oxygen? And as long as it is, I'm not worried. Perioral cyanosis, this is much quicker because we've see it's surrounding the mouth. So your lips are again pink, your mucous membranes are pink. It's again uh, considered part of peripheral cyanosis, and it's vasoconstriction of vessels in the face, and again increasing venous prominence. This is something again I don't it's difficult to differentiate with family history, meaning the history the family gives, because I think when they see it around, they will say the lips are blue. So photos, videos, all of those help. In person, it should look closer. It should be easier to identify. And then pseudocyanosis, I'm forgetting. Yeah. So this is Paul Carrison. He famously took silver supplements for 20 years, and that's what his skin looked like. But yeah, bluish discoloration of the skin and mucous membrane. So this isn't necessarily happening at the vascular level. It's happening, your skin is pigmented. So should not blanch at pressure and is unresponsive to oxygen. And drugs that cause it, so heavy metals, but chlorpromazine, amiodarone and minocycline. Amiodarone is more in the cardiac world for arrhythmias. But yeah, heavy metal toxicity is probably the most you're going to see it in a non-medical setting, or if it's a first-time new patient. And methemoglobinemia, so again, normal saturations, but your pressure of oxygen is uh, in the blood will be different, and this needs a high clinical suspicion. But this is just showing twin siblings, and one of them had congenital methemoglobinemia, so you could see just a slightly more bluish discoloration, again with normal SATs. And yeah, that's by coax because you need to see uh, you're looking at the different forms of hemoglobin for methemoglobinemia. So just going now with that background, and I'll go into the cardiac causes later, just work up relevant history. So what the child was doing. Again, were they playing, bathing in cold weather? Where was the color change? Again, you talk about arms and legs, lips, trying to figure out peripheral versus central. Other symptoms, if they're happy, playful, and it's just the arms and legs, that's different from someone who's gasping to breathe and looking blue, and how long it lasted. Um, Child doing also, you're looking into feeds because you could have, especially in infants, things like choanal atresia, or even things like that causing cyanosis, or if they were crying or fussy, because then you're thinking, was it a breath holding spell versus was it something more serious like a TET spell or PH, pulmonary hypertension event? So examination, again, this is kind of just doing a complete examination, but pulmonary, you're trying to localize, is this the lungs, or if this is the cardiovascular system where you're looking for a murmur and a loud P2. You're looking for perfusion, understanding in an acrocyanosis you have delayed cap refill, but your pulses should be fine. And chronic cyanosis is associated with clubbing. So probably not in your infants, but if you're really getting this history and it's clubbing, clubbing is almost always pathologic. If there's cyanotic in front of you, and my next slide will go into intermittent cyanosis, but that's actually almost convenient in a sense whether it's acrocyanosis or because you can tell the SATs in the moment. And the way I say is if they look blue and you put a pulse ox and it's 99%, that's really reassuring because you've concerned, again, for cyanosis, what we're trying to figure out is hypoxemia. And once we get it normal, um, that's reassuring. Again, doesn't rule out methemoglobinemia, but that's clinical history concerns how they're looking. You're looking into all of that. And pulse ox is negative and child is well appearing. Reassure family based on everything I've mentioned so far, how benign acrocyanosis is, how common it is, how it's not an indicator of low oxygen levels. And that's what so you're counseling on the mechanism, why the kids look like that, the venous pooling. You don't want to give them a specific end time because I said it can happen at any age. If you tell them they'll outgrow at 1 year and then you have a 13-month or a 14-month-old kid who may have it, um, again, if your physical examination is reassuring, they may have it, it may come and go. There's no quick, uh, definite end date. Usually, as they're older, they just regulate it better. And then, of course, if you've got desaturations, we'll talk about that. But that's where you're getting to, hey, this is not right, and we can uh, follow that accordingly. But intermittent cyanosis, so again, it's tricky to always determine the etiology. If families get a video or a photo, you can say this looks like acrocyanosis or perioral, but if they're just giving history, it's tough to say. B- in and if it's intermittent, their SATs will be back to 100% during medical evaluation. Honestly, and I think most of us share this experience, owlets just cause a lot of problems. Uh, if you know the family has it, I mean, told a few to put it on because it does act as a reassurance. I'll never ask them to get one. That's a lot of problems. But if they have one, you're saving. And they tend to be the family who'll benefit, want that information. So if they have it, they can use it. And if it's persistent, bring in for evaluation because again, then we can tell for ourselves, is this acrocyanosis? Is this central? And we can get our own. We can put our pulse ox and get it. I talked about location, central versus peripheral. Acrocyanosis affecting both the limbs. Uh, most pathologic causes of cyanosis should affect all limbs and mucous membranes because, again, your oxygen levels are low, you're hypoxemic, and that's going throughout the body. You're not getting, except in differential, I did add differential cyanosis as well, but in, older kids and all, you're not getting oxygenated blood to one limb and deoxygenated to another in the absence of a PDA. So the rare vascular malformations in thoracic outlet is if there's something causing venous compression and making it look prominent, that one side will look cyanotic. Those vascular malformations shouldn't be episodic, and thoracic outlet can be, but that's with positioning of the arm, and it's honestly not a pediatric thing. It was just when I was looking into unilateral one limb cyanosis, that's what you're worried about. So causes of intermittent cyanosis. So benign, and these are the most common. Um, Most common is just acrocyanosis, like we've gone over. And then if you get a clear history of the baby crying and actually holding their breath, a breath holding spell, which can be common in children as well. Then causes requiring non-urgent evaluation, Raynaud's. This is more classically cold, but then you get that classic color change of, blue and then the red with reperfusion. And then vascular malformation. Because again, these are not immediate urgent things unless, of course, Raynaud's you're showing signs of ulceration. The more urgent ones are mostly cardiac, but intermittent aspiration. Like if you're having feeds and choking and then turning, you want to intervene quicker. Tetralogy of Fallot, their SATs baseline can be lower. They can absolutely be hanging out high 80s, but they could also be normal. And then a TET spell would be intermittent cyanosis. These kids get really blue, like completely blue. Usually after a fussy episode, but could happen after feeding. And we'll go over TET spells or a pulmonary hypertension crisis, which I'll also go over in a bit. So, and that's your the probably the triaging based on what you think. And history and examination should help you determine the cause before testing. So just because they're having intermittent cyanosis doesn't mean you need to do a lot of additional testing because, again, most likely thing is acrocyanosis. Just a quick word on Brewy, and this is where I was saying the hospitalists are probably dealing with it much more than I am. It's a brief, resolved, unexplained event, an earlier, much scarier term used for it. And you've got cyanosis, poor tone, abnormal breathing pattern, altered responsiveness. Interestingly, if a cause is found, you no longer use that term. Like if you find out, let's say a scary example was a pulmonary hypertensive episode, it's a brief, resolved, explained event. But less than 5% are due to any. So again, with episodic cyanosis in young infants, less than 5% are due to anything problematic. And I've mentioned this word a lot, exaggerated autonomic responses. And again, that's what's happening. You're not regulating your blood flow at a microvascular level, and your veins are becoming more prominent. And again, a little bit of development immaturity. More recent guidelines, and I'll say this is more recently than my residency, I think they're getting stricter and stricter with limiting excessive testing and admission. Um, where I know back in when I was early in residence, I think it was less than 60 days, and I think we're getting lower and lower. Uh, but yeah, because they're most frequently benign. So now getting to hypoxemia, um, and that is low oxygen saturations. And the pathophysiology, so there are four main mechanisms of becoming hypoxemic. One is hypoventilation. So uh, this is respiratory depression from the CNS level. So in babies, it's hypoxic ischemic encephalopathy. In older kids, if they got a stroke or drug overdose. In teenagers, so that's hypoventilation, where you're just not breathing fast enough to uh, get your saturations or yeah, get your saturations normal. Then two respiratory ones is impaired diffusion from alveoli. This is any your bronchiolitis, your pneumonia, and that's the most common in children. You've got VQ mismatch, which is respiratory mediated, which is uh, could be either you're oxygenating the things which are not being perfused by the arteries, uh, or reverse, you are getting enough blood flow to areas with low oxygen. So this is a combination, could be with the pneumonia where you have a higher blood flow, could be pulmonary embolism. So less common. And then of course you've got your right to left shunts, which are your cardiac causes, whether it's at a PDA level, whether it's a ASD, or whether it's a more severe congenital heart disease. And just again, we all know hypoxemia is bad, but going into what the problems are, why we uh, treat it is because low oxygen levels, your it's causing an inflammatory state. And we know inflammation both short term, of course, we know it's problems, but long term, continuously being exposed to inflammation. So that's why if we think the episodic cyanosis is a problem, and we still want to treat it because your talk pot is higher inflammatory state. In those moments, you've got lactate buildup, and over time, you've got irreversible organ damage, liver, kidneys, brain, and chronic hypoxemia. So whether it's a NICU stay kid who's been on needed oxygen support for months, or the cyanotic congenital heart diseases, which we see in cardiology clinic, uh, you do have development behavioral issues, lower school performance, ADHD. So even if it's not all the time, that's why we're treating hypoxemia. If your SATs are dropping below alert, that's why we're admitting those kids with RSV. But that's why also if it's episodic and we want to make sure there's no hypoxemia. A good example of this is obstructive sleep apnea, right? Because they're in their sleep, they're snoring, they're having uh, obstruction to their respiratory tract, and they're not getting oxygen. And you're seeing this, those are the kids with ADHD. And that's why we treat obstructive sleep apnea. So then, if you've confirmed hypoxemia, and by that, that's as simple as your pulse ox is low, start supplemental oxygen, improve saturations, titrate upwards because we're avoiding tissue hypoxia. And then you're using history and physical examination to guide workup. A neonate is very different from an infant, from a toddler. Um, the absolute most common thing is going to be a respiratory infection in children. I think that's far and away 90% of these cases. Chest X-ray is a reasonable first step, especially if the diagnosis is not obvious. You don't need to get an X-ray in every bronchiolitic. And uh, going over again, respiratory causes are most common. And by respiratory, this includes infectious respiratory. I should just clarify. But that's the most common reason kids have hypoxemia, which is also going back to PALS. Ultimately your cardiac arrest is also in children is most common also due to hypoxia due to respiratory causes, more so than cardiac causes. Your threshold for cardiac workup is lower in neonates because, again, at that time we haven't ruled out congenital heart disease. I say, if you've had a 3-year-old, he's playing, he's laughing, he's coming, whether it's an infection or something's not right, it's very unlikely. Um, 3 years of his life, he's lived a normal life. He had a cyanotic heart disease. If they had, and it's not impossible. We see it. We have transfers from neighbor islands, limited care settings, but especially if they've been here, the threshold's really low. And classically, saturations not improving with oxygen are more cardiac as well. But again, I think of that mostly in neonates. Okay, so uh, going talk about neonatal hypoxemia, and you may have those signs prenatally, where could be a indication for induction or C-section, where you've got low fetal heart rate decelerations. Initial saturations are lower, and again, the example for this is which is why we're tolerating 85% at 10 minutes for NRP, even though for 85% is not normal. Part of it is the lungs are still recovering. They may still not be optimized, but also the pulmonary pressures are really high at this time. So I talked about a PDA and an ASD a couple of slides back. Um, that's when you're going to have right to left shunting at a PDA, and at 1 hour of life, that's not unusual. The pulmonary pressures are so high, and that will lead to differential cyanosis. But if they still have a PFO and ASD, which most do, you can have just generalized cyanosis because they're right to left shunting at the ASD. But yeah, by CCHD screening, we know our aims are 95%. I was looking into papers which see what's it in that first day of life, you know, before 24 hours. And usually we accept, I think the paper said most of them are 88 to 95. So we don't cross that 90% immediately at 10 minutes or 1 hour. You've got it for the first 24 hours. So uh, you don't need to necessarily react to those low normal saturations at that age. And I mean, even in the 3 months I've been back and in fellowship, we've also had kids who didn't pass their CCHD screening. They were 90 to 93%, and their pulmonary pressures were a little high, and they needed oxygen for 2 days, and um, they just needed a little time, and that's delayed transition or persistent pulmonary hypertension, but may not be signs of anything long term. So neonatal hypoxemia, and this is goes much more into the NICU, and this is by no means extensive. You've got transient tachypnea of newborn, respiratory distress syndrome, meconium aspiration, birth asphyxia, HIE, and HIE goes into the impaired, the CNS causes as well. And then cardiac causes are cyanotic heart disease and persistent pulmonary hypertension of newborn. So workup, chest X-ray, I think every single one of those things I've mentioned outside of CNS causes have their own classic chest X-ray. Get upper and lower extremity saturations. This does help more in neonates than any other time. And consider echo because if there's no obvious respiratory cause, so you don't have that marble glass appearance or the fluid in the streaks. And if it's unresponsive to oxygen, and also if there's significant pre-post difference. So if you've got a huge difference between the upper and lower, uh, it could just be right to left shunting from the PDA, which needs time, but we diagnose that by echo, or it could be a sign of other congenital heart disease. And ideally, you want an echo first, but if you're on the neighbor island and if you're worried about perfusion, much more than cyanosis, you can start PGE as a stopgap measure because you want to keep that open and in most cases, there's no harm and we can always turn it off. This is, again, in an emergency situation, if the kid is cyanotic, hypoxemic, and you're having perfusion issues, uh, keeping the PDA open is reasonable. And before I talk about congenital heart disease, just getting to the last point, which is tissue hypoxia. Different from hypoxemia, we are mainly thinking of the first one, which is hypoxia, which saturations are dropping. Your body needs a certain amount of oxygen to do all its things, and it's not getting it. Whether you're talking about, gut perfusion, and in kids needing oxygen, uh, risk of neck or brain or the brain, and long-term effects of that. But that's due to low SATs. Everything else is not due to SATs, but the body is still not getting the oxygen it needs. So it's reverting to anaerobic mech. Circulatory is your shock. So not enough blood getting to the distal extremities, and so they're extracting whatever bit they can, which is why again you look blue because you're um, in acrocyanosis and the benign causes, it's just moving slower to the periphery and you're extracting more. But in here, you're extracting more because you're not getting any blood at all. And you're just trying to use whatever you get. Same thing with anemia because hemoglobin, its function is to carry oxygen. So if you've got a hemoglobin of 4 or 5, it's usually severe. It's not the 8s and the 9s who are going to have this. You could, again, have that be hypoxic. And a lot of time that's acutely anemic because if you're chronically anemic, the body's adapting and making those changes. And histotoxic hypoxia is basically poisoning, cyanide, where you've got adequate blood flow, you're adequately oxygenating it, but the body can't use it. And this is going to the intensive setting. If you are hypoxic, you should be on way to an ICU or a PICU somewhere. But it is cause dependent, right? You're going to treat anemia with a blood transfusion, histotoxic hypoxia, their own specific antidotes. In most cases, though, supplemental oxygen isn't a bad thing, right? Because you're not getting enough oxygen to the thing, to the periphery. You just saturate the blood, try to get as much oxygen as you can. And then a perfusion in all of them, no matter what the cause. If it's cardiogenic shock, of course, you want to be careful with fluids and you'll have other sides. But in all others, more fluid, you're just getting more um, fluid going to the tissues, more oxygen. And now I'll focus on some cyanotic congenital heart disease. So this is just, I won't be going on to the ASTs and VSTs, but just if you've got, we were talking about in neonatal hypoxemia, you've got a cyanotic kid, doesn't seem to be respiratory, what the most common scenarios could be. And the number one is tetralogy of Fallot. Among cyanotic heart diseases, it is the most common. Every single one of these has a classic X-ray appearance. I've seen it in some of these cases, but by no means are they diagnostic. It's more the boards like it, but also it's prompting you to get an echo. And tetralogy of Fallot is you've got 4 parts. Um, you've got a VSD, right ventricular hypertrophy, the overriding aorta, which basically means the aorta, instead of coming here, from the left ventricle, it's coming from both the ventricles. And you need a VSD almost to have the overriding aorta. And then you have pulmonary stenosis. And all the problems from tetralogy of Fallot, we call it tetralogy, trace down to the pulmonary stenosis, where there's narrowing in that area. It may be the valve, it may be below the valve as well, but it's not allowing enough blood flow to go to the pulmonary arteries. So the blood, and there's a right to left shunt, goes to the left side of the heart. So at baseline, as I said, because there's a little bit of shunting here, you will have your SATs may not be 99%, they may be 88, 92, and we tolerate that uh, to let the child grow, and I'll go into that in a bit. So yeah, and the degree of problems depends on the degree of stenosis. If it's really mild, most of the time the blood, because the left ventricle is higher pressure, most of the blood will just go to the lungs. If it's incredibly severe, some of these kids may need PGE where nothing goes front and you need everything's going into the VST. But that brings me to TETS spells. Like I mentioned, pulmonary stenosis is a key driver, but it's not necessarily fixed. So the valve may be a fixed size and small, but there's muscle below the valve, and that can be more dynamic, and that can affect your degree of pulmonary stenosis. Like I said, we tolerate SATs in the 80s, but during a TET spell, what's happening is uh, kids, either due to feeding or um, fussiness, the feeding, you're just increasing the pressure here, and fussiness, you may have muscle clamping down here. There's no blood going here. And then instead of going here, it goes to the body, makes them bluer and bluer. And it ends up being a cycle because now they're in distress and they get fussier, and lactate tends to increase, and acidosis tends to increase pulmonary pressures as well. So further blocks of blood flow, more goes. So it can be an endless cycle, and it can be a cause of mortality, which is why if you have a TET spell, and we recently had a case, you're operating within a week as soon as possible. Yeah. Uh, but yeah, so you're seeing less and less blood flow go to the pulmonary arteries, and if it can't go there, it has to go to the body. So, and treatment is you're basically trying to open up the pulmonary arteries, either by relaxing the child, and that's where morphine comes in, or you're giving oxygen, which is a vasodilator, or you're just trying to increase the fluid. Like the logic is if you've got more fluid in your system, maybe some of it will push through the muscle bundle and go here and reverse that cycle. So fluid bolus. How propranolol works is if you're slowing down the heart rate, um, then you're allowing this to fill more, and it's indirectly increasing the fluid per pump. So that's why we're slowing down the heart rate. It also may have a muscle relaxant effect if that's an issue. Knees to chest also is getting back more fluid to the heart. So your aim is to get them out of it, and knees to chest is something the family could do. So that's what we counsel them and everything else in a clinical setting. If it's really severe, you just keep a esmolol infusion because propranolol is an oral medicine, especially if they're actively blue and they may not even tolerate PO. So that's an ICU. What you don't want is to increase the body blood pressure and increase the heart rate because that's the heart's filling even less. And what the body blood pressure may do is it may redirect more blood to the body as well, which you don't want. So yeah, with each of these, I'm mainly dealing with what you're going to see in a more acute state, how you're going to manage it, because definite for any cyanotic heart disease is surgery. Timing depends on how the kid's doing. If they're satting low 90s, a bigger kid is a better surgical candidate, so we just tolerate it. Uh, so transposition of the great vessels, this is just aorta comes from the right ventricle, pulmonary artery comes from the left ventricle, and because the of how they're aligned, they're right behind each other on the X-ray. So normally we see a little wider, we see both the vessels separately, and that's what gives it an egg on a string appearance. And this transposition of great vessels is like tetralogy, we deal with slightly older infants, still infants. This is neonates. Like we're dealing, and most of the time they're presenting really soon after birth because they are very cyanotic and cyanotic enough to look blue. So you may not have to wait till the newborn screening. And what's happening going here is, blue blood is coming from the body, going to the body, and red blood from the lungs, whatever little there is going back to the lungs. These need an AST to survive because otherwise they're two separate systems and nothing comes back to the lungs, and that means the SATs just drop quicker and quicker. So you need an AST um, to survive. And the size of the AST will often be demonstrated in the saturations. Like some of these kids I have seen in the high 90s because they've got a wide open AST, and what's happening is the blood from the lungs is going from the left atrium, and the AST is large enough that it just goes to the body. But yeah, you need an AST to survive. You also start PGE, but PG is not enough without an AST. So if the PG isn't improving SATs, you and call the cardiologist. We're going to open the septum up. Comparing transposition, cyanosis is the most severe thing here because respiratory distress in congenital heart disease is often due to a lot of blood flow to the lungs. Um, Here, the lungs are not getting blood flow, so they end up being cyanotic. But yeah, you're mainly going to deal with these in as a newborn in the nursery. It's very rare that it's not going to be found. Hopefully, we find it prenatally, but and then you've got TAPVR, total anomalous pulmonary veins returns, and this is basically somewhere the pulmonary veins do not come to the left atrium. They're going into the right atrium somehow. Most commonly, they drain through a vein into the SVC. Sometimes they go directly behind the right atrium, sometimes into the IVC. And this is called a figure of eight sign or a snowman sign. And it's seen with supracardiac TAPVR because you're seeing this extra vessel. So the veins drain into this vessel, which is pretty dilated. It's dilated enough that you see it on X-ray, which then the SVCs over here drains into the SVC, making it look like an extra round thing on top of the heart. Like a So how they present, um, they can be cyanotic at birth, but this may not be as extreme as transposition because what's happening is you're getting blood, oxygenated blood, pulmonary veins are doing that. It's coming to the right atrium, and a lot of this depends on how it's mixing. If most of it goes to the left ventricle, then you may still be saturating okay. Because keep in mind, there's no other place blood is going into the left ventricle. So it's all from the pulmonary veins, just indirectly. Um, and just the way, and this is, we don't see it well on 2D, but everything, how the veins are aligned, they may point blood in a certain direction. So the veins may still, it may come here, not completely mix, and more go here. That's a lot of streamline. It's called streaming. So they may be cyanotic, but not as extreme because the body is still getting red blood. Often they present like almost like a pulmonary hypertension thing, a little bit of cyanosis. They may also have respiratory distress, and that can be more prominent than the cyanosis. And the reason for that is um, blood has to circulate. So blood from the body goes to the lungs, and then blood from the veins also goes to the lungs. So the lungs are dealing with two or three times the amount of flow. So maybe not the best example, but you do see pulmonary opacities here as well. So the distress can be pretty severe. And in these cases, the reason I'm talking about it separately and differentiating it from transposition is you want to avoid PGE and oxygen. This is a case where PGE and oxygen uh, can be life-threatening because all it's doing is increasing pulmonary blood flow even more. So again, you're going to diagnose these by echo, but if you've got more suspicion, um, you avoid these because these can make it sicker. The perfusion should be okay, and that's why a few slides ago when I talked about waiting for an echo to get the start PGE, this is the main thing I'm concerned about, a TAPVR. Everything else you'll survive it, you'll do okay with PGE and oxygen. And management is surgical. Transpositions we repair at a few days of life. TAPVR often can be the first day if there are any concerns. It's probably the earliest a child would get a neonatal surgery just because they it can be life-threatening. And lastly, pulmonary hypertension, uh, which is in five types. So the one we see most often is PH due to lung disease, and that's WHO group 3, and that's in our BPD patients and um, yeah, any chronic lung disease. Adults see left heart disease a lot because the rest are all rarer, and we'll go over. So all babies technically have pulmonary hypertension at birth. Um, whether you use the word pulmonary hypertension, I actually tend to sometimes prefer high pulmonary pressures because their lungs are just not working at that time, and that's how they should resolve over the first day of life, and sometimes um, and actually takes a few days to weeks to normalize, but severe pH should be better within day of life one. But if you were to echo a 4-hour-old kid, you will very frequently see bidirectional shunting signs of pH, but this isn't true pH. If it's taking more than a day or two to drop further, we use the term persistent pulmonary hypertension of newborn, and those are also the kids, the ones who take time to resolve, but once it resolves, hopefully they remodel and shouldn't be an issue. In infants is type 3, that's lung disease, and we talked about adults. Congenital heart disease, if we leave a shunt open for too long, that's Eisenmenger, and that's type 1, and that's mainly there are permanent changes in the pulmonary arteries. And so I've talked about it cyanosis, but what's important to emphasize is cyanosis only happens if you have a shunt. So here I think this more is a VSD, but more commonly it's a PF or a ASD. So you've got high pressure here, so blood backfills, goes back to the right atrium. If you don't have a PF or a VSD, there's no right to left shunt. So those patients will present as syncope because what's happening, no forward blood flow, nothing comes back in the veins, so they don't have cardiac output. So, and it's important because if this kid has had an echo for whatever reason and they don't have any shunts, makes you feel better about pH, if they're getting cyanotic. Um, and yeah, you treat the more common causes with oxygen, nitric oxide, and sildenafil, and you use echo basically to trend how they're doing. Uh, Echo doesn't I sh gives us an idea of pH, but it's an indirect estimate because I'm not directly in there measuring the pressures. We're not doing things like Korkov sounds or anything like that. I'm just looking at how fast blood is going and taking a guess. pH crisis is similar. You're ramping up the oxygen nitric, and you can also relax the kid, sedate the kid. Behaves very similar to a TET spill. They get fussy, they raise their pulmonary pressures, though the mechanism's a little different, uh, but you're treating them similarly. Um, Normally, it should be a known pH, so you shouldn't have a pH. Like if you're a healthy child and you don't have pH, and again, doing normally, and if you suddenly have a cyanotic episode, you're not having a pH crisis because uh, your pulmonary pressures need to jump a whole lot, and normal kids don't uh, do that. You probably have some pulmonary hypertension at baseline. So either we know of that, if you were a NICU grad or you're a young kid. They're rare idiopathic cases, but they will have progressive fatigue and they give that history. It's not a random cyanotic episode because I have gotten the question, how can you be sure that the blue spell they had and not seen isn't this? It's just the pressures shouldn't jump high enough, right? Because to have right to left shunting, your pressure here needs to be higher than the left ventricle. And if your left ventricle, even low end of normal is 90, this normally hangs around in the 20s. So even if it was to double or triple, that's not good enough. So it has to be high to begin with, and you would probably know that. So pH crisis is mainly an issue in known pH. And of course, there are a lot more cyanotic heart disease, but I just wanted to touch on the more common ones and the ones you could be worried about presenting as cyanotic, episodic or really sick at birth. So special situations, and this again, if you're seeing congenital heart disease in the outpatient world, older kids, there are situations I may never be able to make the saturations normal because there are only so many ways you can reconnect things. And with tetralogy of Fallot, the reason we're tolerating ATs is because neonatal surgery is a huge risk factor. I talked about how hypoxemia lowers, causes development issues and all of that. Well, so does neonatal surgery and neonatal ICU stay. So I would rather tolerate SATs of 88, 89% than put a kid through surgery at 10 days of life because the surgery is probably going to cause more long term. So you may, especially tetrahydrophilo, because it's common, you may have a patient and when you screen them, them SATs may be 90, 88 or 89, and we just tolerate it because it's harmful. And then there's some surgeries, and we won't go into them, but where I cannot make it, meaning the surgeon cannot make your SATs normal just because there's no way to get 100% of the oxygenated blood back to the body. I also say most of these cases, if you know they have cardiac surgery, they sometimes have a disproportionate decrease in saturations in response to illness because they're very sensitive because any issue with the lungs, and this is going into pH and other things, increases pressure, increases right to left shunting. So not only are you dealing with lung disease, you're dealing with more right to left shunting. And we just treat it normally. If oxygen helps, we can give them, but there's it's just getting used to the fact that your their SATs may be lower than expected. And if there's a congenital heart disease, we talk to them about what the expected saturations are. We don't have a lot in Hawaii, but Glenn, for example, we say your SATs are between 75 and 85%. So if you have a kid with a heart scar, and you measure the SATs and it's 80%, just check with the family because you don't want to be giving oxygen if they don't need it. And also you may not be able to get it up. So then um, it leads to unnecessary medical management. I added this because despite what we do, if we can't, they do have that effect. Uh, and we can't change that. The IQ is a little lower, and I'm sure over time, keep finding ways to improve that. But um, this was to bring back home to the point that hypoxemia is not a good thing, and made remarkable progress. They're living longer lives, but they are affected by what they went through in their infancy. That's what I've got. I think we've got a few minutes for questions.
Awesome. Thank you. Perfect timing, really. Maybe why don't we get the question polls started, and then that way everyone can compile their questions for you as well. And that gives us hopefully a little bit of time to go over all the answers.
Okay. Yeah. So, question one, which of these patients is most likely to be cyanotic on examination? So I think it's kind of the jury's between the polycythemic kid and the anemic kid. And I realized, there are two things I talked about which can makes this a little confusing. But yeah, higher hemoglobin saturations because cyanosis is dependent on the uh, amount of deoxygenated hemoglobin, so around 5 grams. So if you're at 22 grams, even 90% can make you look bluer. We talked about how anemia, you could have tissue hypoxia, but that I did say more in the acute anemic setting. So in this kid who's got chronic anemia, with a HP of 5, just 90%. In fact, for him, it among all these kids, he would need the lowest SAT to demonstrate because he can almost never have a deoxygenated hemoglobin content of 5 gram per deciliter um, because he's just that low. So anemic kids, it's harder to detect cyanosis on, and if they look, you should be concerned about hypoxia. But in this case, he's probably compensated. And in polycythemic kids, they're most likely to appear blue. Any questions with that one?
I think you can just go through
Yeah.
them.
Okay. Yeah. And then the next question. So, baby comes in with these cyanotic episodes, and he's blue in front of you. So, in terms of next step, again, do the and physical exam because we've talked about how the sensitivity and specificity is pretty poor, and also with having the normal oxygen levels, it acts as a source of reassurance. And then you can yeah, change the environment, but also once you've confirmed it's normal, it doesn't need to go away for the family to be discharged. They need to be reassured it's a normal thing. But yeah, your next step is still confirming cyanosis or hypoxemia versus no hypoxemia. Um, and yeah, this is going into your NRP where at 10 minutes you tolerate 85 plus. If usually at 10 minutes, if they're 80 to 85, we would do a little bit of oxygen. And it takes a full 24 hours to get to 95%. And at 15 minutes, they may not still be there. So 85%, this is just, I changed the number a little bit from 10, but you'd expect them to be. TED spell, we talked about how higher heart rates are a problem. I did mention epinephrine can also increase the pulmonary resistance, which is not a good thing. And uh, this is going technical words, technical terms, hypoxia versus hypoxemic. Uh, so, so they can absolutely be hypoxic if they have shock. Drugged out.
Thank you so much for going through all of those. I know that we're a little bit over time, so I do want to be mindful of everyone's time. Renata did have a question very on early
Yeah.
on. So I'll just pass that one on where she was asking if you always expect blue or if you can sometimes see other like lighter discoloration, if that would
It,
also qualify as cyanosis.
it's usually in the blue shade, blue purple, but like I wouldn't call white a cyanosis. I think that was I was trying to place what time in my talk that was, but yeah, I wouldn't call white a cyanosis.
Okay, good. I haven't seen any other questions come through yet. And again, since we are actually a little bit over time, I'll just say thank you at this point so much. I learned a lot. That was a very good refresher for myself as well, and a reminder that we really don't see a lot of these kiddos in the hospital, but it's good, at least not on a hospitalist setting, but really good to have that reminder, especially for all the neonatal things that I know all of our specialists in the outpatient field will deal with much, much more. So thank you so much again. Thank you everyone for joining us. I am terrible in that I did not pre-check what our next session will be, but I believe, correct me if I'm wrong, Summer, that we are going to be starting our next pediatric mental health care series. Um, next month. So that'll be our first session on November 5th. And we'll actually be talking about billing and coding, which I know is everyone's favorite topic, but I think really good to learn more about. So hope to see you all there.